Anaerobes. All right, so the definition of an anaerobe is an anaerobic bacteria that fails to grow in the presence of air or carbon dioxide. A moderate anaerobe can't grow in anything greater than 2 to 7% oxygen. So a strict anaerobe can't grow in anything more than 0.5% oxygen. So some anaerobes are considered what we call aerotolerant because they are capable of growth in room air and carbon dioxide, but will grow best in anaerobic conditions. Since oxygen is a killing agent for an anaerobic organism, we have a very strict collection and transportation process. It's a setup for strict procedures for anaerobes. So if they are not followed, you can have contamination by normal flora, as well as having overgrowth by facultative organisms, and again, death of the anaerobes when they are exposed to the air. So that's why it is important to follow the procedures put in place for these types of organisms. So collection, transport, and setup are pretty defined parameters. There are 4 principles regarding anaerobes, which are proper collection and transport, culture of the specimen as soon as possible. And if you're truly doing anaerobes, you're going to have like an anaerobic chamber that you will set up. So it's a specific hood where all the oxygen is purged before you actually plate the organisms. So we will talk about some of the different media, but make sure to review that in your book as well. And then we will also talk about incubation at proper anaerobic conditions. And specimen plates are usually not looked at until 48 to 72 hours after they have been inoculated. So anaerobic cultures are not a rapid turnaround time. They take a little bit longer than your regular anaerobe organisms. The other thing with anaerobes, because of the items just listed, such as overgrowth by normal flora, growth of the facultative organisms, that can be both aerobic and anaerobic. So we have a pretty strict specimen list as well. So everything that you see listed are considered unacceptable anaerobic specimens. So examples would be throat specimens, nasopharyngeal, gingival, exportated, sputum, sputum by the nasotracheal or oral tracheal suction, and bronchial washings. From the gut, we have gastric or small bowel contents, large bowel contents, colostomy effluents, feces, except for C. diff, rectal swabs, and pararectal abscesses. For the genital urinary, we have urine, vaginal, and cervical swabs, which are not accepted. And then superficial open skin lesions are also not accepted. Acceptable specimens for anaerobic cultures, we have specimens from the central nervous system, like cerebral spinal fluid, abscess aspirates, and tissue biopsies. We also can get specimens from the oral, ears, nose, and throat, so aspirates from abscesses and even tissue biopsies. We can get them from the pulmonary or the lung area, so the transtracheal aspirates, lung aspirates, pleural fluids, and tissue biopsies. Genital urinary specimens as well, like the suprapubic aspirates. And some other sterile sites like blood, bone marrow, bile, fluid from other normally sterile sites, and tissue biopsies from normally sterile sites as well. So just an additional note, so best specimen types for this are tissue samples and aspirates, and this is due to reduced contamination and better recovery of those anaerobes. For specimen handling, we have processed specimens as soon as possible after collection or store at room temperature until processing to maintain anaerobic viability. So we can do a direct examination of anaerobic infections. They typically will present with a foul odor, commonly associated with infections involving the Fusobacterium species and the Porphyromonas species. We'll have exudate with black discoloration that can fluoresce as red. So the characteristics of infections can involve the Porphyromonas species and the Prevotella species. We can also have presence of the sulfur granules, and this will be indicative of infections with the Actinomyces species. We can also have sulfur granules that are small yellowish granules that can be seen in pus or tissue that can represent bacterial colonies. Anaerobes have their own growth requirements. So some augers will be supplemented with hemin or vitamin K. Almost all of your auger will be pre-reduced anaerobically sterilized media. Primary isolation will normally be on a non-selective anaerobic blood plate, which is not the same thing as your aerobic blood plate that we've talked about in previous lectures. Typically some type of anaerobic selective media and oftentimes liquid enrichment media as well. We can also use for non-selective, could be like Brucella blood agar plates, and selective, and again, these are all anaerobes, so we have PEA, LKV, BBE, which is Bacteroides bioesculin, and EYA, which is egg yolk agar. Your gram-negative anaerobic bacteria. So one of the first things you need to do with your genus is separate them based on the gram stain results, whether they're gram-negative or gram-positive, and whether they're rods or cocci. So gram-negative anaerobic bacteria are Fragilis bacteroides, Bacteroides urolithicus, Provotella, Porphyromonas, and Fusobacterium are gram-negatives. These are the gram-negatives that, again, are anaerobes, are usually an endogenous infection, so, within the body. Of course, if it's within the body, they don't have exposure to oxygen. Infections can be polymicrobial, so you could potentially recover more than one pathogen. So do remember that anaerobes can be normal flora of the oral cavity, upper respiratory tract, GI tract, and female genital tract, which is why the majority of those specimens are rejected. And anaerobes can be considered an opportunistic pathogen. All right, so we're going to dive a little bit more into each organism a little more individually. So first we have Bacteroides fragilis. It is the most commonly isolated anaerobe in a clinical infection. It is a predominant member of the large bowel, and it can be isolated from the decubitus foot ulcer, bloodstream, and female genital tract. And the organism is encapsulated, so therefore it's often resistant to phagocytosis. Bacteroides fragilis is a gram-negative, non-spore former. It's non-pigmented, non-motile, and it is an obligate anaerobe. Encapsulated and can produce beta-lactamase. So that is one of your key ID characteristics, is it's resistant to all. So it's resistant to colistin, kanamycin, vancomycin, but it will grow in 20% bile. So it will be positive on your Bacteroides bioesculin agar, or your BBE agar. Gram stain will be a pale pleomorphic gram-negative rod, and you can perform aerotolerance testing to determine if the isolate is an obligate anaerobe. But again, Bacteroides fragilis is the most commonly recovered gram-negative rod, and it is resistant to colistin, kanamycin, vancomycin. So those would be the things you're going to want to remember for this organism. Bacteroides urolithicus is responsible for deep-seated infections. It's considered a microaerophil. It is normal flora of the oral cavity, and it's associated with localized infections of the mouth. It can also be recovered from pulmonary, head and neck, intra-abdominal, and urogenital or soft tissue specimen types. So our characteristics for Bacteroides urolithicus species is that it is asaccharidic. It is non-pigmented, non-spore former. It is a gram-negative rod that may actually pit the anaerobic blood plate. It is sensitive to bile. It does require fomate and fumarate to grow, and demonstrates sensitivity to kanamycin and colistin, but is resistant to vancomycin. All right, so Provotella species, it may be pigmented. It's found in orofacial lesions and pleural pulmonary infections. It's normal flora of the oral cavity, and we see this in infections of the head, neck, lower respiratory, female urogenital specimens. Again, it's a gram-negative rod, non-spore former. It's an obligate anaerobe. Some pigment, but it may take up to 21 days for that to actually develop. It's a fastidious grower, so it's a picky eater. It's resistant to vancomycin, kanamycin. It's variable, has a variable response to colistin, and it is susceptible to 20% bile. On a gram stain, you're going to see a short coccoid pleomorphic, so it's going to have varying types of shapes. It grows on the LKV agar, which is where you look for your pigment production. And when it does show that pigment, it's going to fluoresce as a brick red color. Porphyromonas, these are typically involved in oral infections such as a root canal infection. Porphyromonas gingivalis is a component of dental plaque and is a pathogen in periodontal diseases. This is an obligate anaerobe. It's a non-spore former, and it can be pigmented. It is a gram-negative rod. It is the only gram-negative anaerobe that's susceptible to vancomycin. It is resistant to colistin and kanamycin. It's asaccharidic, and it is susceptible to bile, indole positive, and it is non-motile. So asaccharidic refers to the organism's inability to ferment or break down sugars or saccharides. So the organism does not produce enzymes capable of metabolizing carbohydrates like glucose, lactose, or other sugars to generate energy. And then we have Fusobacterium species. We have 3 different species. So we have Fusobacterium nucleatum, Fusobacterium necrophorum, and Fusobacterium mortifera. These are generally found in the head and neck infections, brain abscesses, chronic sinusitis, and liver abscesses. It is weakly asaccharidic. It is GLC, so it produces, or in GLC, it's a gas liquid chromatography, which is actually a definitive process for identification of anaerobes. Your identifying agent is going to be the production of butyric acid that will indicate that you have a Fusobacterium species. It is a non-spore former. It is an obligate anaerobe, and it is resistant to vancomycin, but it is sensitive to colistin and kanamycin. So Fusobacterium on a gram stain will give us a thin gram-negative rod with some pointed ends. Fusobacterium nucleatum colonies have like a flecked appearance or breadcrumb appearance. It is an obligate anaerobe. It's resistant to vancomycin. It is indole positive, lipase negative. Again, the gram stain will be a rounded or tapered end with coccoid bodies to filaments. Fusobacterium mortifera on gram stain will be extremely pleomorphic, filaments with gram-negative bacilli with some swollen areas or round bodies and irregular looking stain. Veillonella parvula. So Veillonella is the 1 gram-negative cocci that you will need to remember. So out of your anaerobes, Veillonella is your only gram-negative cocci. It was frequently recovered with oral bite wounds, head, and neck wounds samples. For gram-positive anaerobic bacteria, these organisms are components of the normal flora of the skin or mucosal surfaces. They can become opportunistic pathogens by spreading to adjacent sterile sites. Some common routes of spread can include trauma, aspiration, and alterations in the normal flora, like using antibiotics. Most of our gram-positive anaerobes are what we consider opportunistic pathogens. So they're associated with exogenous infections. They typically produce toxins as a virulence factor, and generally they are susceptible to the beta-lactams. So think of your like penicillins with beta-lactams. Peptostreptococcus is now called Anaerococcus. It is a gram-positive cocci, which is arranged in tetrads in chains. So same sort of arrangement as the aerobic Streptococcus. Can be normal flora of the mouth, upper respiratory, skin, large intestine, female genital tract. It is an obligate anaerobe. Can be found in blood cultures and can cause bacteremia from the female genital tract or contamination during a draw. Anaerococcus is resistant to kanamycin and colistin, but susceptible to vancomycin and SPS. Propionibacterium acnes has a diphtheroid appearance. This is the most common gram-positive rod that is seen in clinical specimens. It's isolated from skin, intestinal abscesses, plaque. Propionibacterium is often considered a contaminant of blood cultures, but you'll need to assess, if it is actually a contaminant or not. So again, it is an anaerobic bottle, and you would look to see are both sets of the cultures positive. If that's the case, it could potentially indicate that it is actually a contaminant. And as the name indicates, this is actually associated with acne. Actinomyces. Actinomyces infections usually result with a purulent discharge that do not contain sulfur granules. They will have a diphtheroid, club-shaped, or filamentous rod with some branching. Actinomyces, as a normal flora of mucous membranes, such as the mouth and the genital urinary tract. We see infections with actinomyces of the tissue, bone, and cervical. This can cause pelvic inflammatory disease, especially in women that have IUDs. Actinomyces is often seen in the mouth area, and it can cause what we call lumpy jaw. So it's an abscess that actually comes from the sinus tract, but due to the swelling of the face and the location, it's referred to as lumpy jaw. So if you look at the picture, that'll kind of give you an idea of what it causes. The colony appearance will look like a molar tooth or a breadcrumb. All right, so we're going to switch gears a little bit and talk about anaerobic gram-positive spore-forming bacillus. So everything that's in your Clostridium genus or Clostridoides genus will fall into this. They are aerotolerant or obligate anaerobes. They're typically found in soil, dust, and water. We can see endogenous infections as well as exogenous. So your exogenous infections would include tetanus, so Clostridium tetani, gas green, Clostridium perfringens causes myonecrosis, so that's the death and dying of the tissue. It can also cause food poisoning. Then you can use egg yolk agar to identify your Clostridium species. They are typically susceptible to kanamycin and vancomycin, but are resistant to colistin. Your most common isolates are going to be Clostridium perfringens and Clostridium ramosum. Clostridium perfringens, this is a gram-positive spore-forming bacillus. Again, it causes gas gangrene and necrotizing disease of the bowel and even toxin-mediated food poisoning. The gas gangrene will often see in a diabetic patient, so usually it's an extremity that starts with a small toe or the foot, and the nursing staff will typically notice a blackening of the skin, and that's due to the necrotizing or the death of the tissue. So as you can see in the picture, that would kind of be an example of what you would see. So when cultures grow, we will get a double zone hemolysis. So that is a key characteristic to remember for these guys. On gram stain, they typically have a boxcar shape, so a little wide and pretty blunt on the ends. They are lecithin positive, lipase negative, Nagler positive, and reverse camp positive. So lecithin, lipase negative, Nagler, and reverse camp are used to differentiate your Clostridium species. Clostridium botulinum is a large pleomorphic organism with rounded ends in singles or pairs, can be chains or club-shaped as well. This causes botulism by ingestion of a preformed toxin. Clinical diagnosis can be confirmed by a stool culture or toxin activity in the serum. Lecithinase negative, lipase positive, and botulinum is a motile organism. Clostridium tetani is a slender rod with rounded ends and a swollen terminal spore. So oftentimes this is going to be referred to as a tennis racket shape. So you can see in the picture of the gram stain, it kind of looks like a tennis racket or a badminton racket or something of that nature. Tetanus is a toxin mediated due to a puncture wound or soil contamination. So that's why we get our tetanus shots, and then if you stepped on a rusty nail, they would give you another one. We usually are not able to recover this in a culture, so tetanus is going to be diagnosed based on the patient's presentation. And then we have Clostridoides difficile. It is a gram-positive or gram-variable organism. It's a major cause of antibiotic-associated diarrhea and pseudomembranous colitis. It can be normal flora. It does produce an enterotoxin A and a cytotoxin B, which is what causes the damage to the membranes in the colon. Caused typically by prolonged use of antibiotics. So basically the antibiotics that this patient is on changes the normal flora in the gut, which will result in diarrhea with the patient. And then the causative agent is Clostridoides difficile or C. diff. But we usually do not typically culture for C. diff. This is usually going to be confirmed by a cytotoxicity assay. So C. diff is known for producing a distinctive horse-stable odor, which is kind of like a strong, musty smell. It can be cultured on psilocyrin cephaloxatin fructose agar, or CCFA, which is actually selective for C. diff. They are lecithinase negative and lipase negative. For that CCFA agar, it is a selective and differential agar that is used to isolate C. diff. It contains cycloserine and cefoxitin antibiotics to inhibit most other gut bacteria. This includes fructose as a fermentable sugar. C. diff colonies typically will show a yellow color due to the fructose fermentation. For the lecithinase test, this detects the enzyme lecithinase, which breaks down lecithin, which is a phospholipid in egg yolk agar. A positive test will show an opaque or white precipitate zone around the colonies. C. diff is lecithinase negative, so they do not form that precipitate. Lipase test will detect lipase enzymes which hydrolyze lipids or fats. A positive test will show a shiny iridescent sheen or color zone on an egg yolk agar. Once again, C. diff is lipase negative, so it will have no reaction. The primary treatment for this will include stopping the offending antibiotic that caused disruption of the normal flora in the first place, and further treatment may involve specific antibiotics like metronidazole or vancomycin.